Hey guys, welcome to tonight's live Q&A with Dr. Michael Pikos. Let me add him on here. Dr. Pikos.
Hello, Shane. How are you?
Hey, good evening. How are you?
Good evening. Great. Thank you.
Awesome. Well, appreciate you joining us. We'll give just a couple of, maybe a minute here while it looks like people are joining here pretty rapidly. So those of you who are joining us here, we appreciate you taking a little time with your evening to ask and get some questions answered with Dr. Pikos. If you guys have any questions, please type them. You can put them in the questions icon there, or you can put them in the chat. I'll be looking in both areas, and we'll try to get as many questions answered as we can. Brief introduction. I think a lot of people on this Instagram live session probably know who you are, but Dr. Pikos is an oral and maxillofacial surgeon, has the Pikos Institute in Trinity, Florida, also has a private practice in and around that area, and been doing continuing education for a long time, and been a friend to osteogenics and a friend of mine for a long time. So we appreciate you being on with us.
No, the pleasure is mine. I very much appreciate being asked to be part of this event, and looking forward to some questions from our audience, and welcome all of our colleagues who are taking time to be part of this.
Awesome. Well, I'll jump into it. Excuse me. I've got a couple of questions while we wait on some questions from the audience. And these are questions that I've been to enough of your courses and your symposiums to know what kind of some of the more popular questions. And so let me start off with biomaterial. So whenever you're doing bigger grafts with vertical and horizontal ridge augmentation, what type of biomaterial do you use, and what's your rationale?
Well, basically, it kind of really depends on a couple items. One being the extent of the defect. In other words, the greater the defect and size and even location, for that matter, will dictate the type of material that I'm looking at. So in general, for horizontal augmentations, these are the most predictable that we can do, and can get some fairly great results with basically allografts in general. But I always add a xenograft component. I've done that for goodness, almost close to 30 years now. That xenograft really acts as a great material that does not go away. And that's really the whole idea of it. In other words, to maintain dimensional stability of our grafts, I've always used roughly a 70-30 mix of allograft xeno for most of my augmentations in general. And I use that same combination even when I'm using BMP. So in general, horizontal augmentations, allograft xeno works well. If I'm able to have autogenous bone, which many times I am in that area, then I typically will take advantage of host bone. And I like the Micros scraper in general.
Okay.
That allows me to harvest autogenous bone rather easily. So in general, autogenous bone, I'll go more for vertical augs than for the horizontal. But the xeno is the constant for sure. That's again the one that just, long-term stability is fantastic for maintaining, again, dimensional stability of the overall, graft result.
Yeah, I think that's a pretty common, using some xenograft, definitely not all xenograft, but some is a pretty common protocol for, I'd say some of you guys are having, doing the most of this and maybe having pretty good success. So that's a pretty, it seems like it's almost, dare I say, universally accepted that a little xeno in there helps maintain the stability.
Yeah. In general, the vertical grafts need more of the autogenous component. And in other words, we need something that has osteogenic capacity above and beyond. Obviously the allograft is more of a scaffolding item, biomaterial that, doesn't really have any osteogenic capacity per se. It's more of an osteoconductive particulate graft, of course, but we're able to still get great results for horizontal aug. But again, the greater the need for osteogenic capacity, that's when we'll go more to autogenous. And I love BMP. I've used it for goodness over 16 years and well over 500 grafts using that protein, which is of course is the only protein we have that forms bone de novo. So still need a filler, as we know. So that filler would still be roughly a 70-30 mix of LO-Xeno, even with BMP.
So the BMP, I think that's a great, we can pivot into, like, how often are you using that? It doesn't sound like you're using it in every case. When do you decide to add the BMP or not?
Primarily vertical augmentations, to be honest,
Okay.
or if there's a combination horizontal, vertical, any vertical component in general, that that's what I'll call a true 3D defect, meaning horizontal and vertical. It's pretty unusual to have only the vertical component.
Sure.
So in general, vertical BMP. Now it depends on the location. Like for example, many posterior mandible cases where I need maybe 4 or 5 millimeters of vertical. That's a block graft for me. That's the same. Recipient donor site, one and the same, can harvest the block rather easily, efficiently, quickly, and utilize it for 4 or 5 millimeters of height, and then I can come back with implants. Goodness, we can use shorties now. It's been about 12 years that I've used shorty implants. Minimum height for me is 6. So 6 and 7.5s. I've used the Bi-Horizon system for about 18 years. So those are my go-to implants for many cases where don't have to get more than 4 or 5 millimeters of vertical. And then we've got, good bone to work with. Some of those same cases have the height of maybe 8 millimeters, 7 above the bundle, but need width. So we'll just graft for width and then place the shorties. So that's autogenous block bone, of course, and been doing those, my goodness, since 1990. Have well over 1,000 of those done. Very predictable, very predictable. And kind of combination with, in the last 10, 12 years, more of a GBR block approach where we, use the collagen membrane cross-linked with some particulate bone, depending on the extent of the defect, in combination with the block. Yeah.
What's your how long are you waiting on these? So these are the ridge augmentation cases, the bigger cases. So how long are you waiting to go back in and place your implants if you're not doing immediate?
In general, BMP cases in particular, 7 months. That's a definite.
Uh-huh.
I know a number of folks talk about 5 or even 6. My experience, waiting only that time frame, not a good D2 quality bone, more of a D3-ish. 7 months minimum, and it's D2 pretty routinely with BMP. Now that bone is still maturing. Takes about a year plus for complete maturity of the BMP bone. So, but we typically have a D2 quality at 7 months that we can place implants and even load them for that matter. So in general, that's the time frame for BMP. For the LO-Xenos, 5 months typically, depending on, again, the extent of the graft and the volume. The greater the volume, I'll wait longer. Waiting 6 months or so is not such a bad thing for those types of augmentations, yes.
Are you waiting? So I'm hearing 5 months on if it's just allo and xeno together without the BMP, and you're going 7.
Say a 1 site, the smaller the graft site, then obviously the reentry time can be that time frame. The larger the graft, then pushing closer to the 6, even 7 month mark.
So is that longer time period, the 7 month for the BMP cases? Is that because the BMP needs a little bit longer to turn into, just as far as healing times, it just, you have better quality bone then? Or is it more related to the fact that you're just using the BMP in the bigger cases and the bigger cases need longer?
Well, it's the time frame is dependent, right, on the turnover of the graft complex. So it does take about a year for good maturity of that grafted site. Uh-huh. So keep in mind, the biology of BMP being a mitogen morphogen, it literally, as you know, will differentiate a cell line from stem cell all the way to an osteoblast. And then the osteoblast, of course, lays the bone down. But that whole process to get mature bone, because see, we can get lamellar bone really within a week. It's amazing. Or I should say osteoid. Early osteoid is in 1 week, 7 days for BMP. However, for that graft turn over and become a good type 2 quality bone, mature, quote unquote, it's about 12 months. It's almost really what the sigma is in bone in a human with say a fracture. So we know that from the literature that it takes a good year for that fracture to become quote unquote totally healed. And when it's healed, it's fantastic D1 bone, the fractures. But look back now with BMP, healing process is a little bit different in terms of it's a particulate complex we're looking at. But in order for good, solid, mature bone, it's literally a year. But once again, at 7 months, we can place our implants and even load those cases and treat it just like it would be a native bone site.
Got it. So pivoting a little bit to smaller defects, ridge preservation. I want to talk about that, and then I want to talk about immediate versus delayed. But looking at ridge preservation first, I know that you use a lot of our Cytoplast TXT singles, the single tooth membrane left exposed when grafting extraction sites. You recently asked us to make a longer one. So instead of 24 millimeters long, it's 30. Can you talk a little bit about why do you need that? Why do you need a membrane that long, and exactly like when are you using it and how are you using it?
Well, just a quick backstory on that. I've been using the 12 by 24s, my goodness, for as long as they've been available. It's got to be a good 16, 17 years now. Very predictable. In fact, probably the most predictable graft that we do. In other words, a true socket graft extraction site, pretty much anywhere in the mouth. We're basically able to, if I can't do an immediate implant, then my plan B is, of course, grafting the socket. So we're able to use allograft only, and that's been mineralized allograft for all these years. Very predictable turnover. But the key is that membrane, which really is a fantastic membrane to utilize in those cases because of the fact that it allows what contains the graft, certainly, and it was, as you know, manufactured to be exposed to the oral cavity. So that said, I use it in a true pouch mode. In other words, I'm creating a subperiosteal pouch on both the facial and lingual aspect of the tooth site and that extraction site. So therefore, in placing a particular graft, the membrane then is tucked typically on one side and then over into the pocket on the other side, and very careful suturing over that. That membrane is just a fabulous adjunct for allowing us to get this predictability because it A, confines the graft, and B, allows you to remove it. Typically, I remove it routinely at 4 weeks. I just like that time frame. So let's say time 0 is now. In 4 weeks, I have the patient back, take out sutures, and which are typically PTFE for me, 3-0, nice crisscross horizontal mattress that goes directly on the membrane, and then typically a couple single interrupted, and I remove those sutures and the membrane all at 4 weeks. For the longest time, I would have the patient at 2 weeks, take out sutures, 4 weeks, take the membrane out, waste of time for the patient and for us. So at 4 weeks, everything comes out. And to the patient, I mean, it's amazing. D2 quality bone, ultimately at 4 months, but also a keratinized band of tissue across that crest, very, very routinely, very predictable. So we really benefit immensely with that protocol. Now, that said, in some molar sites, that buccal fascia or buccal palatal dimension can be wider than, at least for me, the 12 by 24, barely getting depth into those pockets.
Okay.
So that's why I'd asked for the 12 by 30, and you folks were very kind enough to accommodate me. And I do believe it's available now. In fact, I am certain for everyone. Yeah. So that has really been the solution to the issue that I've had, where I've got that gap, that longer span, I should say. Instead of trying to do two 12 by 24s and overlapping, you can do that, but one 12 by 30 is perfect, typically for maxillary molar sites where, again, that dimension facial palatal is quite long, and there's quite a span there. So the membrane works beautifully for that. And I'll tell you what, it's so predictable. It's crazy. It is the most predictable graft, I would have to say, that I've done in my entire career. And that membrane has just been superb for that application.
Awesome. Well, I appreciate the kind words, and I know it's definitely. I mean, it's kind of like what Osteogenics is known for is the textured dense PTFE membrane with ridge preservation, and now we have it in the longer size. And I honestly I wasn't sure. I thought maybe you were using it for larger like buccal dehiscence defects, which leads me into another question. Are you doing the same protocol if you have if you missing that buccal plate after extraction?
I am basically. In fact, the facial plate up to maybe say a 3 millimeter defect or so, straight Mineros by itself as Mineros allograft works nicely. I will add as the defect continues, especially if the plate is blown out, then I add typically recombinant PDGF or Gem 21, and that really is a tremendous adjunct. That protein really recruits cells so nicely and allows for a very predictable turnover for that missing facial plate. And but same membrane protocol. I used to tack those cases, open up, in other words, have surface release incisions. I found out that's not necessary. Can get away with basically an envelope incision and tucking that membrane on the facial, and then grafting against that membrane, and then tucking it, of course, into the lingual pouch, and waiting. Actually, in those cases, 5 months. So I had 1 month to the reentry time, and very predictable once again, very predictable. That same case now, if we have a lingual plate issue as well, in other words, what I call a true 3D defect of the socket, now I pull out the bazooka, which is BMP. And that is perfect for those kind of defects that, in other words, giving me predictable results. And that's what it's about for all of us, of course. I used to play with BMP for just a buccal plate blowout. Waste of monies there. As we know, it's fairly expensive, about $675 for a double X 0.7 cc dose.
Okay.
Don't need it in those blowout cases of just one plate, but 2 plates involved, yes. And very predictable, maxilla and mandible, by the way, right in and around the sinus. Just amazing results.
Awesome. So, audience, if you guys have any questions, you can put them in the chat or in the questions icon. I should be able to find them either way, and we'll try to get your questions answered. Next question that I have is immediate versus delayed. So in extraction sites, how often are you doing immediate implant, if at all? And if you are doing some, how do you decide to do immediate or delayed? Like, what's your criteria?
The criteria are fairly straightforward. The real short answer is really if I'm able to get good primary stability of the implant, then it's a done deal. And that's what I really strive for in each case. No question, it's convenient. It's convenient for the patient, certainly for us, and certainly our restorative colleagues. Everybody wins. But again, practicality, just stability by itself isn't the end all be all. Wanting to make sure that the end result is going to be something predictable from an aesthetic perspective. So if we're looking out of the aesthetic zone, in general, say posterior dentition, bicuspid molars, upper, lower, again, we can get away with a little bit more wiggle room in terms of an aesthetic result. But again, if it's a thin phenotype, I get more concerned and tend to shy away from immediate cases in general. The hybrid and the thick phenotypes, fair game. So we can get primary stability, typically having enough bone apical to the socket without compromising whether it's a neurovascular bundle for a lower case or potentially a sinus. But upper sinus is not a problem. We're able to do simultaneous socket grafts, more I should say sinus lifts via the socket. So we can do that nicely, especially with VersaBurst. Now it's been 6 years I've used osteodensification drills that work quite nicely in those extraction sites in the upper molars, for example, where I would only I would shy away from and not place an implant immediate. Well, as long as I get stability once again, then we're fair game, and I can simultaneous graft well within the sinus. And because we can densify the bone, so that works out well. But when I can't place and I'm not comfortable with stability, well, then that's a grafted socket. And once again, there's the, the cytoplast membrane that is just truly such a convenient membrane to have for those cases.
Yeah.
And again, if I have, defects that are a couple, 3 teeth even, then the membranes still serve a great purpose as well. And there I tend to fixate those and get primary closure in general, but not always. Not always.
Okay. Got it. I want to switch gears a little bit to peri-implantitis. And so I happened to see George Katsakis joined us a few minutes ago, and I know he's doing some really interesting research and things with
Yes, he is.
peri-implantitis. And so on that topic, that's something that I don't know, I just found myself more and more interested in because in learning more about it. So, what are you doing? Are you treating peri-implantitis? How often are you just extracting the implant? I've asked several doctors the same question now, and the general answer that I hear is if it's your implant, you're treating it. If it's someone else's implant, you're extracting and putting in a new one. And then there's also the more and that's, I think that's sort of a joke, but also probably sort of true a lot of times. But then it kind of depends on maybe how expensive the prosthetic is, and if you're going to lose it if you have to replace the implant. But is that like how do you differ on that, and what are your thoughts on treating versus just starting over?
Well, lots of points here to really address, Shane. First things first, in general, if it is somebody else's implant and it's compromised in terms of bone loss and a true peri-implantitis where you've got the soft tissue element, the bone, typically in general, the rule of thumb is I'd rather remove that. But the real rule of thumb is if we're up to about 50% thread loss, then that implant's going to be gone regardless.
Yeah.
Worth it. So short of that, in terms of how do I approach those cases, well, I will tell you, we had George at our symposium this past fall, our annual Pikos Symposium. Every other year, it's hard and soft tissue grafting is the theme, and that was it this year. And we had George as a speaker, did a marvelous job, as he always does, speaking on peri-implantitis. And the latest and greatest that I got from him, and I kind of knew about it from a few months prior because he had also been he's a faculty member at the Pikos Institute now for the past 4+ years. So I had to speak to our group in August. So I was pretty much aware of his protocol. And that's pretty much, and even before then, but I've now adopted that. It makes sense. And in a nutshell, it just makes so much sense. It really does. You can throw away all of the different protocols that are out there in terms of adding, Lord knows, pick an item in terms of trying to, number one, detoxify, quote unquote, the site from citric acid to peroxide and you name it, and maybe even throw in some ouzo. But the bottom line is nothing more than saline soaked sponge will cleanse that implant as well as anything, believe it or not. Of course, debridement, obviously, of any granulation tissue to start. But when you're down to bare metal, then really, I love what George has shown, and his studies validate this protocol, and that is you don't even have to smooth threads like a number of us have done over the years. We've pretty much tried everything like most folks. But the long and short of it is, rather than throwing everything but the kitchen sink, really the graft complex that he has suggested and again shown with his research is nothing more than the novabone particles. So that is an interesting biomaterial because obviously it's alloplast. I'm not a big fan of alloplast in general, never have been. The only alloplast I've really played with to any degree, it's been about 6 years now, and that is novabone putty for my crestal sinus grafts. I mean, that's a fantastic biomaterial that does turn over. We get radiographic evidence of that, and I've even done some reentries where I'm able to, biopsy, or I should say, do some histo, get some histo on those cases, and it's amazing mineralized matrix that works quite well. So in a nutshell, it's nothing more than utilizing gauze soaked in saline and basically following that with the alloplast and getting closure. So membrane, yes. So that now it's been just a few months I've worked with that protocol, and I'm going to be able to see results hopefully soon. But I like that. It just makes sense.
Mhm.
But most importantly, there's science. It's not just what works in my hands kind of thing. George is anything but that. He's an amazing research-based periodontist that has really done amazing things and well published for his relative young age. I'm so impressed with what he does. So I like that protocol, and that's what I've transitioned to after utilizing a number of different ones that are kind of hit miss, to be honest. I think we're all in the same boat trying to come up with some silver bullet.
Sure. Yeah.
And this may not be the silver bullet, but it makes sense. And what I saw from his research, truly, there's validation there. Yeah.
Very cool. So I want to ask you some questions about the upcoming Urban Pikos Symposium, and also just your institute in general, because I think you've been an innovator in sort of private continuing high level continuing education for dental implants and bone grafting. And so I want to pick your brain on a couple of things there, but I just want to ask one quick question from the audience here. They're asking, whenever you're cleaning an infected site prior to ridge preservation, what's your protocol?
An infected site. Well, in general, what I had been using forever, citric acid of the implant itself. If we're looking at, oh, I'm sorry, you mean
We're talking about ridge preservation of extraction with an
oh, I'm
infected
sorry.
site.
For immediate placement in general, I mean, good debridement of the socket is critical.
Mm-hmm.
Mechanical to start, and then rotary, get good bleeding bone.
Okay.
So that sets up the site for immediate placement or grafting. Again, if I can't get immediate stabilization of the implant, then it's a grafted site. Yeah.
So very like a very aggressive, kind of like mechanical removal. Are you doing any antibiotics?
Correct. No antibiotic.
Okay.
Nothing in site per se. No, not at all.
Okay.
Good debridement, get good bleeding set, but it really takes some time to when I say good debridement, I mean that they're blind sites that you don't realize and can leave residual granulation tissue, especially with periapical lesions. Want to make sure everything is removed very, very well, and then again, either immediate placement with grafting or grafting by itself.
Got it. Perfect. I think we answered that one. So I want to talk about the Pikos Urban Symposium. So it's May 5th to 6th, 2023, and there's actually workshops on May 4th. So I think you could think of it like May 4th to 6th at the Ritz-Carlton, Orlando, Florida. In preparation for this, live Q&A, I just went on your website and made sure I had the facts right, and I noticed that the early registration, the discounted registration, actually goes through December 2nd. So it's good timing just to bring that up with that coming up pretty soon. So my understanding is, and I've been to one, but I believe, do you guys do one day all you, one day all Dr. Urban, or do you do like a half day each day? And just tell me a little bit about what's the idea behind having, I mean, it's the two of you on stage for 2 full days. I mean, I think that's pretty apparent what, the attractiveness of that. But, what was your idea behind pairing up with him and doing it in that format?
Well, I kicked it around for some time, and he and I did talk about it for several years before we did our first one, which was, 4 years ago, roughly 5 years ago. So we decided to do it every other year. And after the first session, we both felt it was, really great success, and we both liked it. So got great feedback, and then did it again. So this will be our third iteration. But in a nutshell, it just seemed logical to pair us up because, we've got a European version of bone grafting, more or less. And then you've got more let's call it the American version or U version. So there's contrasting styles to a degree, but yet we have a lot in common. Right. Surprisingly, and maybe not so surprisingly, because let's face it, biology is biology. Mm-hmm. And you can't, fake things out and expect good results. So the long and short of it is, I just felt we had so much to offer, again, in common and yet not common, that we could together form a nice 1-2 punch that, I think would be of value to our colleagues. in one place and one venue. So with that said, it made sense to go right to the Ritz-Carlton, where I've been going for many, many years. When I did, I teamed up with Maurice Salama, our partners in Synergy. For goodness, that was about 16 years roughly.
Oh, wow.
And that was a great ride. And it's, as is true for anything, things need to come to an end at some point. And now with this fund, we're calling it 3.0 and the finale, because we both agreed, let's maybe take a rest for a bit and just kind of see what happens. But we've had, again, great success the past 2 sessions, and we're already, based on the registrations we have now, we're spot on for another great turnout. But the bottom line here is we're able to utilize the following format, and that is day 1 is mandible. I have the morning, basically half day, and Isfan has a half a day. Day 2 is the maxilla. Again, I have a half a day, he has a half a day. Okay. So we're showing basically the spectrum of what we do. And for me, it's compressing, my goodness, all my courses into a full day of lecture discussion, which is very difficult to do. But I think what's important is to showcase not so much step-by-step protocols across the board. That's not possible, but definitely enough pearls and enough insight to be anything but, hey, look what I can do and how great I am. None of that nonsense. It's more of, look, these are the basic incision designs, flap reflection, different ways of periosteal releases, on and on and on. And I draw from my subperiosteal implant experience for showcasing, for example, lingual flap release. As you know, or may not know, but I use blunt dissection for the most part, finger dissection since 1990. And of course, it's fun, a little bit different approach, and is same end result, that we get tremendous flap elongation up to 25-30 millimeters, et cetera, but just different approach. Right. And my sub days, and still do those subs, by the way. We have severely atrophic mandibles. That mylohyoid muscle is right at the crest. So when I did my first case in 1990, it's like I'm staring at this metal, and how am I closing around this sub without getting incision line opening? Facial, flap release is one thing, but I've got to do something on the lingual. I'm not going to put a blade there. So I just start playing with literally my fingers and thumb and trying to just stretch the tissue, and sure, separate the superficial from the deep mylohyoid muscles, etc. And I was able to get primary closure, and as they say, the rest is history. I applied that same protocol now over 32 years, and that's what I've been teaching ever since for posterior mandibular cases where we're grafting, whether it's hip graft, tie mesh, blocks, GBR, it doesn't matter. We can get tremendous release. And then in the anterior mandible, lingual site, I taught myself how to basically relax that tissue over the framework. And that's the only place I use sharp dissection. For example, lingual anterior floor of the mouth area, where I'm able to brush literally the periosteum in such a way that you can elongate again 15-20 millimeters, et cetera, et cetera. So contrasting ways of doing things, getting the same end result. And I think that's what is so important for our colleagues to appreciate, that yes, there's more than one way to skin a cat, certainly, and then difference in grafting materials. That this one's more autogenous / xeno. Big reason our European colleagues can't use allografts. So we do things differently. Allo-xeno, as I mentioned, some autogenous, sure. Whenever I can grab it, why not? It's going to kickstart the whole regenerative process, et cetera. Why not? For sure. So again, different, iterations of how we do things. So bottom line is it's a full day. I mean, 2 full days, I should say, of lecture discussion, Q&A. And then, as you mentioned, the day before is the workshops. They always close out fast. I recommend anybody signing up for that symposium. If you're interested
in some seats open in the workshops.
Pardon me?
Are there still some seats open in the workshops?
Oh, there definitely are, but
okay.
We're about, I'd say, almost half full already, because we each have a workshop morning and afternoon.
Right.
So we're able to accommodate 30, I believe it's 34, 36 folks each of those sessions. Typically, folks will take Urban's and then mine. So it's one person really filling both courses. So really, the seats are limited in that sense, and that's why they fill up so quickly. But really, with all due respect, it's 3 full days of a deep dive into bone grafting from A to Z, meaning a ridge aug, sinus, you name it, from single tooth to full arch, and everything in between. Yes.
That's great. So just for the audience, just to summarize, May 4th is workshops, May 5th to 6th of the main symposium is 2023, Ritz-Carlton, Orlando, Florida. If you go to the Pikos Institute, or it's not the, I'm sorry, just pikosinstitute.com, you can get all the details. Also, all the rest of your courses are on there. There's 5 or 6 different topics that you cover. I know there's one more this year coming up in December on fully guided full arch immediate implant reconstruction. And so go to pikosinstitute.com for more information on that. My last question for you is November 26th at 11 a.m. Ohio State, Michigan. What's the final score?
Well, that's 11 a.m. your time. It's 12
noon your time.
Eastern Standard Time. I will be there, as I always am, for the home games. My prediction is I think the Buckeyes are going to win by 12 to 14 points, believe it or not, 42, 24 to 30-ish. I'll just call it 42, say 27, 15-point spread. I know it's going to pee off a lot of my colleagues. But
that's
quite
the point, right?
2 decades plus, I have been, on the winning side. Michigan did pull out a really strong game, came to play and really kicked our butt. So a lot going on in this game. This turnaround back to Columbus, and we're pretty much wanting to get a little revenge. So should be fun.
Yeah.
2 great teams, no question. I think represent the Big Ten quite well. Solid teams. One more pass-oriented, which is us, and one more run-oriented, which, of course, is Michigan. So it's going to be fun. Going to be probably pretty chilly, but should be a good game. Yep.
Awesome. Well, we've gone over. Time flew by. I really appreciate how open you are and all your great answers as always. Appreciate your time, and we'll talk to you soon. And thanks everyone who joined us. We appreciate your time as well.
I thank you, Shane, and our audience as well, taking time out of your busy schedules to be with us for this session. I've enjoyed it, and again, it's fun to share any of our material that we can, ideas, concepts, you name it, with our colleagues. Life is short, and it's all about really facilitating what we learn and passing it on. I think that's the bottom line. We learn from each other, and it never stops. So thank you very much.
Absolutely. Appreciate you. Have a good night, everybody.
Good night.
Bye.
Bye-bye.